When we first meet patients, we have to ask a lot of questions about the kind of tumor that they have. One of the first questions that we ask our pathologist is, if this is non-small cell lung cancer, is it squamous or non-squamous? Because both of these are really two different diseases. They often respond to some of the same drugs, but also some different drugs. So that's one question. Another question that comes to us when we're asking about immunotherapy is, what is the PDL1 level? And I know there are a lot of videos about this, but the idea there is that the more PDL1 the tumor has on it, the more likely the immunotherapies will work, either alone or in combination. So in this part, we're talking about squamous cell with low or no PDL1. In this space, there's really only one approach that's FDA approved that includes immunotherapy, in my mind, and that is a combination of immune therapy and chemotherapy. A lot of patients ask me, you would tell me that chemotherapy is immunosuppressive, so why the heck are you giving it along with immunotherapy? Well, the answer is those two really can synergize, and we ask these questions in trials. If you give one followed by the other versus giving them together, are the results better or worse? And at least the scientific idea behind it is that chemotherapy tries to blow up the tumor. The tumor, hopefully, if the chemotherapy works, breaks down. Those little breakdown products are circulating through the bloodstream to get filtered out by the liver and kidneys. But part of that process, as those little fragments are circulating, the immune system notices. The immune system is more on guard. And so that might be the perfect time to give immunotherapy. So if patients have high PDL1, which you'll hear about in other videos, you might actually be in a situation where a single agent immunotherapy may be sufficient to get a great response, a great long response. And we usually set that threshold at 50% or higher. When a patient is between 1 and 49%, then we have a choice. Pembrolizumab, or Keytruda, is approved as a single agent, but we do have a lot of evidence that suggests that doing chemotherapy along with the immunotherapy probably works best. And the combinations we use in chemo are carboplatin and one of two drugs in the taxane family. One is called Taxol or paclitaxel. The other one is nab-paclitaxel or Abraxane. And when you give those every 3 weeks along with the immunotherapy, that seems to give the best result. There is also the opportunity to give pembrolizumab or Keytruda as a single agent between 1 and 49%, but the study that showed that really did not show us that that achieves better results than chemotherapy alone. So if I'm really going for my best foot forward, I really do like to give that combination of chemo with immune therapy. If a patient has 0% PDL1 on their tumor, then we really do have to give chemotherapy plus immunotherapy, not only because the FDA has only approved that combination, but because that's what we think has the best shot of waking up the immune system enough that the immunotherapy can work. Now, I'm giving this in November of 2019, and of course, research is progressing under our feet. One very interesting study that just came out this year called Checkmate 227 does look at the combination of two immunotherapies, so Opdivo or nivolumab, along with ipilimumab or Yervoy. That combination is actually an approved combination in melanoma, but it's only still being studied in non-small cell lung cancer and hasn't been approved yet. But one of the really interesting findings this year from that study was that whether you have a PDL1 of 0% or 100%, that double immune therapy combination actually outperformed chemotherapy. And the amount by which it outperformed chemotherapy was the highest in patients who had 0 PDL1. So I told you a minute ago I wouldn't give pembrolizumab or Keytruda as a single agent, but if there's an opportunity to use two immunotherapies together and maybe synergize those, that might be a really important treatment option going forward. There are caveats when you give two immunotherapies together. There are more immune therapy side effects, which even if they're less frequent than the kind of chemotherapy side effects can be more severe. So this really will be a risk and benefit discussion with an oncologist, but I do want to throw that out there because that might be an option on the table in the very near future. So for most patients with a low PDL1 and squamous cell disease, I would recommend chemotherapy plus immunotherapy, usually Keytruda with carboplatin and a taxane, but maybe in this near, not too distant future, we'll be looking at double immunotherapy with Yervoy and Opdivo as an option. Finally, I would make a pitch. If you're that patient with squamous cell disease, it still is worth asking your doctor if it makes sense to do next generation sequencing, to go on that search for mutations. Mutations are less common in squamous cell patients, but they are seen. Medicare does pay for next generation sequencing for these patients, and especially if you are a non-smoker or a very light smoker or very light smoking history, or if you're younger than our average patient, sometimes we're afraid that squamous cell biopsy may actually be a sampling error and that maybe you have one of the mutations that's important. So I always want to get mutation testing for all my patients, but especially squamous cell when they're young, when they have a very light or no smoking history. It's actually imperative to look for those targets that might let us give a targeted therapy that pushes chemo and immunotherapy to later on in their disease.